Hey guys, Miss Hill again, and we are going to continue Individual Module 5.2, PowerPoint 2, and this is Lecture 2. We're going to start this lecture talking about nursing care during labor and birth, specifically related to cesarean section. So, why have a C-section? What's the reasoning behind why we would do a surgery to deliver a baby instead of have a vaginal delivery? I have a few reasons listed here for you. Cephalopelvic disproportion. That's one of the biggest reasons why we see C-sections, especially scheduled for first-time moms. So we have a mom who has a pelvis that is inadequate for the baby to come through. So cephalo means head, pelvic obviously is the mom's pelvis. So we have a cephalopelvic disproportion. Remember, whenever we talked about our 5 critical factors of labor and birth in the first PowerPoint, number 3 was that passenger passageway relationship. If we have cephalopelvic disproportion, here is where the problem lies. So the baby can't fit through that pelvis, then we would not put a mom through the stress of trying to deliver vaginally, through the stress of a labor. We would schedule her for a C-section. Now, sometimes we might not know that she has a cephalopelvic disproportion until she starts to deliver, or until she's been through labor and maybe the baby is not descending into the pelvis appropriately. And we may not actually know this until it's time for her to deliver and she can't push the baby down or out. And then we have to take her to a C-section. So the next thing would be non-reassuring fetal heart rate. And this just means that the baby's not doing well. Remember when we talked about fetal assessment in our first lecture for this PowerPoint? The very first thing we do for a fetal assessment as the labor nurse is check out the heart rate and interpret our findings on that fetal heart rate strip. So if we have a non-reassuring fetal heart rate that we cannot correct with intrauterine resuscitation, then that mom is very likely to go for a C-section. Preeclampsia and eclampsia. Those are 2 also big reasons why we do C-sections. Moms with an elevated blood pressure sometimes do not fare well during labor. We talked about all the different ways that the body changes during labor. Remember what we said about the cardiovascular system. With each contraction, we have a big increase in blood volume that returns back to the heart. And for someone who has high blood pressure, that's not necessarily a good thing. Also, the stress of labor, the pain of labor, all of those things increase blood pressure anyway in just a normal person. So for somebody who's preeclamptic and their blood pressure continues to go up and up and up during labor, we don't want to put them through the stress of that. So we may take them to a section. Now, for that individual experiencing eclampsia, that person is seizing, right? Because that is the definition of eclampsia. It's where blood pressure has gotten so high that our mom is now seizing. We don't wait around for a mom to have another seizure. If she is seizing, we get her to a C-section. That's an emergency. We have to get that baby out because remember, the cure for preeclampsia and eclampsia is just delivery of the baby. Failure to progress is another reason why we may send a mom for a C-section. Failure to progress basically means that labor is not going as you expect it to, things are not progressing. The cervix doesn't dilate appropriately. It doesn't efface appropriately. The baby doesn't descend into the pelvis appropriately. And so we may have to take that mom for a C-section because we're only going to allow her to labor for so long. Another reason that we may take moms for a C-section is dysfunctional labor. So if contractions are not adequate to dilate and efface the cervix, then we may have to take mom for a C-section. If contractions get too close together, then we also may have to take mom for a C-section. Remember, if contractions are too close together, then what do we do to the baby? We are cutting oxygen supply off to that fetus, and if we cannot get mom to have a good resting tone in between those contractions, then we have to correct that somehow. Our heart rate's going to go down, the baby's going to become bradycardic, you're going to start seeing decelerations on your fetal heart rate strip, and at that point, we may have to take her for a C-section. So dysfunctional labor can affect C-sections in a couple of different ways. We either have contractions that are not strong enough to progress labor so that mom is able to deliver vaginally, or we have contractions that are way too close together and are distressing for mom and baby, and then she has to go. And then elective C-sections are given to moms who have had C-sections previously, and they are second timers coming back to the hospital. So, move on to the next slide. Okay, so obviously, a C-section is a surgical procedure, and we have to be cognizant of a few issues associated with that. C-sections can be either scheduled or emergent. So, moms are either scheduled on a certain date to come in and have this done, and if that's the case, then they're very likely to have mentally and emotionally prepared themselves for that day. They have their belongings packed. They have child care arranged for their other children. Their family knows where they're going to be. However, if the C-section is an emergent event, then there is a lot of stress that comes along with that procedure. So whenever we have a patient that goes for a C-section, we have to be really aware of the psychological effects that it has on mom and on the significant other or the support person who's there, specifically with those emergent C-sections. So if we have, for example, a baby who has gone bad on us, or a fetus that's gone bad, and our fetal heart rate tracing is not looking so great, and we've got to get that baby out very quickly, then, you know, lots of people run into that room at one time, and they're flipping mom, and they're turning her, and they're starting an IV bolus, and they're giving her oxygen, and there's not a lot of time to do a whole lot of good explaining to her because we have a very short window to get that baby out so that our outcome of healthy mom, healthy baby is achieved. So those have a lot of psychological effects on mom and on the family. It is very scary for that to happen to you. And if it's your loved one lying there, then it's very scary from that standpoint as well. There are risks involved for the mom and the baby, obviously, because this is a surgical procedure. So we have risk for infection, there are all kinds of risks associated with a C-section, same as there would be with other surgical procedures that your medical patients would go in for. There's also a risk of complications for the mom and the baby. And we also, as a labor nurse, have to be aware of those complications as well. Some individuals who have had a C-section are able to give a vaginal birth with a later pregnancy. The only way that you can VBAC, VBAC, vaginal birth after cesarean is what that stands for, is if, number one, you've only had one C-section. If you have had more than one C-section, you are not a candidate to VBAC. Number two, if your uterus was opened up in a classical manner, meaning that the incision to open your uterus was up and down instead of side to side, then you are not a candidate for a VBAC. And the reason for that is because those classic incisions that are up and down are at a much greater risk for rupturing. So if we put a mom through the stress of labor, we put her uterus under the pressure of those contractions for hours on end, then the scar tissue where that incision has healed over in the uterus is much weaker than tissue and the muscle of the uterus, and it's at a much greater risk for actually splitting open. So here are a few of your poor candidates for C-sections. Individuals who are anemic are really not great candidates for C-sections, obviously, because you bleed more, right? If your belly is cut open, you are going to lose more blood than you would for a vaginal delivery, obviously, if it's a normal one. And if you're anemic already, then this puts you at a greater risk for perfusion, for delayed healing, puts you at risk for gas exchange issues. So these people aren't really great candidates. People who have chronic illnesses like cardiovascular disease and diabetes, the same reason they're not great candidates for general surgeries make them also not great candidates for a C-section. The mom with diabetes is not going to heal as quickly. So just because they have these chronic illnesses and it makes them a poor candidate does not completely exclude them from having a C-section, because obviously we have to do the best thing for the patient, but the physician and the nurse have to be aware of the complications surrounding whatever chronic illnesses this patient may have, and the benefits for having the C-section need to outweigh the risks associated with having the C-section because coupled with their comorbidities. So, for example, the diabetic mother is not going to heal as quickly, like a chronic diabetic is not going to heal as quickly as a normal person without diabetes. However, if her baby is too large to deliver vaginally, then we don't have much of an option. The benefits of her having that C-section outweigh the risks to her. Advancing age. These guys are poor candidates for C-sections just because they're a little older, their bodies are a little slower, things don't heal quite as quickly. People who are on certain medication regimens are also poor candidates for C-sections. So, for example, the mom who may be taking Coumadin regularly. That would be a poor candidate for a C-section, especially if it's an emergent C-section. There will be a lot of factors that we have to consider and be able to manage if we had to emergently C-section a mom who was on Coumadin. And then also psychological factors. So moms who have severe psychological issues are also poor candidates for C-sections because they cannot cope as well with the stress of the surgery on top of having a newborn, maybe as well as they could with a vaginal delivery. So not only are we worried about physical issues when we're talking about candidates for a C-section, but we also are worried about psychological risk factors as well, and we can't ignore those or forget about them. So how do we preoperatively care for the individual who's going to have a C-section? One of the big things is we psychologically prepare people for this. If it's a scheduled section, we have a whole lot of time to be able to do that, right? We know that they're going to be scheduled for that section. They'll have a specific day to come in, and we have an opportunity to do some education. We have a much more controlled environment if it's a scheduled section. However, if it's an emergent section or a stat C-section, then our environment is much more chaotic. It's not as controlled, and it's not as easy to psychologically prepare them for the fact that this is getting ready to happen to them. So, as a labor nurse, it's always a really good idea that whenever you are admitting a laboring patient, even if she's going to be able to successfully vaginally deliver, it's always a good idea to psychologically prepare her and educate her that it's a possibility that if things don't go as planned, here are the things you may experience. There will be a whole lot of people that come into the room at one time. We'll all be trying to help get you ready. We may ask your loved one to step out so that we can move freely and easily around the room. Everything will happen very quickly. We may not be able to explain all of this to you at the moment we're doing it, but we promise we're going to review test ability. So those types of educational talking points whenever you're admitting a laboring individual is important to psychologically prepare them for the fact that it's a possibility they may have to have a C-section, because we're never guaranteed anything. Also, for those patients who know for sure that they're going for a C-section, we want to educate them about things that we educate regular general surgeries for. Turn, cough, and deep breathe. The importance of getting up and ambulating after surgery. Their diet, that they'll not be able to eat anything but clear liquids to start with, and that will advance their diet as needed. Different things that they'll be able to receive for pain control. Physically, we also have to prepare people if they're going to get a C-section. We always make that C-section incision low down on the abdomen, and that area may need to be clipped prior to going back to the OR. This slide says shave, but we do not ever shave anybody. You guys know that, I'm sure, from Ms. Thompson's class, but we always clip them. So we have electric clippers, and we may have to clip mom's hair down in that lower region where the incision would be made. Usually the Foley catheter is placed once the mom is on the OR table. If she is getting a spinal for her C-section, then the Foley would be placed after the spinal is inserted. If the C-section is going to be emergent and it's got to happen very quickly, then we will probably put that Foley in prior to taking her back to the OR. It just depends on how quickly we have to get things moving. IV access is also something we have to have, because if mom has to go to sleep, we better darn well make sure that we've got an appropriate IV access to do that. We have to remove mom's jewelry. We don't want anybody wearing any kind of jewelry into the OR. We like to hydrate people prior to them getting any type of general surgery, specifically a C-section, and especially if they are going to use a spinal anesthetic. Spinals have a great risk for dropping your blood pressure, and that's one reason why we like to IV hydrate people prior to getting that type of anesthetic. But also, just in general, we know you lose a lot of blood in surgery, and we want people to be well hydrated. We want their blood volume to be up as much as we can get it. We want their circulatory system to be full. Skin prep is another thing that we've got to do preoperatively. Mom has to be cleaned appropriately. So your OR crew will do this, or this might be the responsibility of the labor nurse who's taking care of this patient. It depends on how your facility works. And then moms get anticholinergics and anti-secretory drugs as well prior to having a C-section. And these drugs are to help decrease acid in the stomach and to help dry up secretions. So as a nurse, there's kind of a general checklist prior to going to the OR. And here are the things that we look for. We've got to have an informed consent. Nurses are not able to get consent from the patient. That is the doctor's responsibility. However, a nurse can witness that the patient signed that consent form. But if the patient does not understand what is getting ready to happen, it is the physician's responsibility to go back in and explain that to her prior to signing that consent. Moms will also get extra lab work if they're going for a C-section. They possibly, if it's a scheduled section, may have an EKG, X-rays, and different types of ultrasound reports. We want to make sure that their jewelry, their contacts, their eyeglasses, any dentures they may have been taken out and have been either stored in a safe place per the hospital policy, so locked up in the safe by the nursing supervisor or handed back to family. One thing we don't want to do is lose any type of glasses, jewelry, dentures that a patient may come to the hospital with. So it's important that we make sure those belongings get where they're supposed to be, and that we do that by the hospital policy. We want to make sure that the patient has the correct attire, and that anybody that's going into the OR with her also has the correct attire. So they got to be gowned up. They've got to have a hat on. They got to have shoe covers. For mom, we put a hat on her so that none of her hair falls out in the OR or falls into the wound. And if we're having an emergent section, then we want to let our nursery staff know. If we're in a facility that is big enough and fortunate enough to have a NICU, then we want to notify the NICU staff that it's possible we may have a baby that's not going to do so well after it's born. If that's the case, usually the NICU at most facilities will send someone from the NICU, a nurse, to attend that delivery. But just in general, you always want your nursery nurse to attend, that's going to attend the C-section to know what is going on. All right, incision to decision. What does this mean? So, take a different look, take a look at these pictures in relationship to the incisions made whenever we have a C-section. So, there are two places that have to be incised whenever you're having a C-section. We've got to cut through the abdomen, and we got to cut through the uterus. Okay? So, a classic incision means a vertical incision. It's up and down. We can make a classic incision on the abdomen, and we can make one on the uterus. A low transverse incision is made sort of in the bikini line, so it's from side to side on mom's abdomen, very low down, and that's made in the abdomen. And the other incision made in the uterus is called a Pfannenstiel. I really cannot say that word. I have such trouble saying that. But anyway, it is basically a horizontal incision in the uterus. But we can also make that classic incision in the uterus as well, which is the up and down. A mom who has a classic incision, remember, will never be able to VBAC because of the risk of uterine rupture. Now, what does incision to decision mean? Or decision to incision. That's actually backwards. So, sorry, I'm having to readjust my feet. They're going to sleep. When we talk about, this slide specifically is talking about the decision to make which type of incision in the abdomen. Now, if you have a patient who previously had a classic incision in the abdomen and a classic incision in the uterus, then the next time she has a C-section, those are more than likely the places where the physician will decide to do the incision the second time around. We just cut back through that scar tissue. We don't want to be scarring up mom's abdomen all over the place. Classic incisions are usually made in a hurry. So if your doctor is in need to get that fetus out very, very quickly, he may decide to utilize the classic incision because it does not take as long as being careful to cut that low transverse and then the Pfannenstiel, whatever it is. It just doesn't take quite as long. So if they're in a stat situation and they're not able to take the time to do that low transverse, then he may make the decision to use a classic incision. You don't see classic incisions very often, but it's very important if you have a patient who's coming in for a C-section that you know what type of incision that she's had, both in the abdomen and in the uterus, because it is possible that her incision on the abdomen is classic, but the incision in the uterus is horizontal. They don't always have to be the same way. Here is an example of a classical incision. So, again, a fast delivery for the infant. It usually leaves a wide, really nasty-looking scar. These moms may experience some low self-esteem because of this new scar on their abdomen. You know, you think about like a first-time mom who has to have one of these or who does have one of these. I mean, this is something, this scar is going to be on her body forever. Will never be able to wear it again and probably not feel comfortable in one. So this is a big deal to cut somebody this way. These people will always have a repeat C-section if the uterine incision is classical. And you can see the other little picture here with the uterus and the classical incision up and down. These guys are high risk for uterine rupture. They will never be allowed to VBAC because of that risk. Low transverse. So, with a low transverse incision, you can see this scar on mom's tummy here. It's kind of sort of right there in the bikini line, very low down on the abdomen. It takes longer to perform this incision. However, moms have less blood loss. This is really what the doctors like to do. And these guys can have a vaginal birth after cesarean if they have no cephalopelvic disproportion. Also, they'll have that little scar line right over the symphysis pubis. And then you can note that uterine picture right there, and that's where they would cut the uterus as well if it's this low transverse incision.
Mama.
Yes, baby. Well, not really, but it's okay. You took a good nap. Sorry, guys. That was Anna Kay. All right, let's talk about infant resuscitation. So, with infants who go through the birth of a C-section, their airway has a lot more mucus in it, and we may have to do some deeper suctioning to clear their airway out and to help them with breathing. Also, the OR is a very cold place normally, so we already know that we need to keep newborns very dry, and we need to keep them warm. So it's important that we dry them off very quickly and get them either under a warmer or on mom's chest, skin to skin. If the baby is stable after the C-section and we've got him nice and dried off and his airway and his breathing and his circulation are good, then we can allow mom to hold and breastfeed in the OR if that's something that the hospital allows where you're working. There's a huge push towards baby-friendly hospitals, and that's a real big thing now, is the skin-to-skin and early breastfeeding, even in the OR. So some facilities have moved to doing that, and others have not. Just depends on where you are. If the baby is unstable and has a low APGAR score, then we're going to have to do some resuscitative measures. And in the OR, usually the people who attend C-sections are your labor nurse, your nursery nurse, and a respiratory therapist. And then obviously you have a anesthesia personnel there. Sometimes you have two. Sometimes you have a CRNA and an anesthesiologist. If the baby is anticipated to be a bad baby or have a negative outcome after delivery, then we would call the NICU staff and the pediatrician to also come and attend the delivery so that we have all the backup we need if we have to resuscitate. If there is some sedation going on, so if we have a baby that comes out that's limp and no tone, what? No, I don't want to be playing with no moon sand today. Listen, I'm trying to record a lecture, so I need for you to let me finish this, okay? Okay, well, I don't have your moon sand here, so let me finish this. Do you want to say hey to my students? No? Okay. All right. Sorry, guys. So, uh, if mom has had some type of um, pain medication that she maybe got during labor. Let's say she got some pain medication during labor and the baby was distressed and now we've had to take her for a C-section. It's a possibility that the baby will be sedated and have some respiratory depression when it's born. And if that's the case, then many facilities give Narcan per their protocol. However, some of the new research is actually showing that Narcan is a bigger risk, that giving it is a bigger risk than just supporting respiration and supporting the airway until the drug will wear out of the baby's system. So there are other facilities who are no longer using Narcan on newborn babies. Instead, they are supporting breathing and airway. I want to take a quick mention here on this slide also about the increased amount of mucus and the reason why we might need to have to suction these infants deeply, more deeply than we would a vaginal birth. That is because with a C-section delivery, the babies do not get that squeeze that they get when they come through the birth canal. So as a baby is born through the vaginal canal, it has to squeeze itself through the pelvis. It's got to squeeze itself through the vaginal canal until it's completely expelled. And there's a lot of pressure that is exerted on the baby as it passes through the birth canal. Whenever a baby is born with a C-section, all that pressure does not happen. We've got an incision and the baby just sort of slips out. There's not that same amount of force exerted on the baby's body. One thing that force, that pressure exerted on the baby as it comes to the birth canal, one thing that it does is it helps the baby expel mucus and fluid in the lungs. So it makes sense that if you have a C-section and all that pressure is not exerted on the baby, then they will be more wet in the chest. You know, their lungs are going to have more fluid, and they won't be able to get rid of that mucus like they would if they were a vaginal delivery. So that's why we see more mucus, and we have to do some deeper suction sometimes in the OR. All right, post-op care. You can see which one is listed first. Imagine that. Preventing hemorrhage. The way we prevent hemorrhage during post-op care is the same way that we prevent hemorrhage for a vaginal delivery. We just have an extra spot that we've got to be assessing now, which is the incision, okay? So we are continuing after delivery, after a C-section delivery, we continue to assess lochia, and we continue to rub the fundus, just like we would during the recovery period of a vaginal delivery, that 4-hour period, that fourth stage. We still will be rubbing that fundus to make sure that it's nice and firm and that mom is not bleeding. But we also, with the C-section, now have an extra spot to look at and assess. We've got to assess her dressing. Just like with all surgeries, if there is drainage on the dressing, if you notice shadowing on the abdominal dressing that's placed over mom's abdomen where she had the incision, then your nursing intervention would be to mark that to date it and to time it so that whenever you reassessed it the next time, you would know whether or not there was any further drainage. However, nurses never remove the initial dressing after an operation, correct? The physician who's done the surgery is always the person that removes that dressing. So if need be, and if the dressing becomes saturated, then what we would do as nursing personnel is reinforce that dressing. We would put another dressing on top of it until the doctor could get there to look at it. And obviously, we would call and report that. Vital sign monitoring is very similar to what it is with a vaginal delivery after a C-section delivery. Every 15 minutes times 4, every 30 times 2, and then every hour times 2. So for a total of 4 hours. With C-sections, we have to be cognizant that these people are going to be in probably more pain than a vaginal delivery, and therefore we have to have some options to manage their pain. If they have a spinal, a lot of the time their spinal will take care of the pain that they feel from the surgery itself. But once it wears off, then we may need to medicate them with things like Stadol or Motrin. Motrin is a really good one, Percocet. Those are the ones that you see ordered the most. Also, with C-sections, post-operatively, we got to measure urine output. These guys will still have a Foley, and when we're measuring urine output, we're also assessing COCA. If that urine is bloody, that is a big red flag, because think about what organs are down in the area where you are making the incision and delivering the baby. The bladder is right there. So if we nick the bladder, then you may see bloody urine, and that's something that would definitely need to be reported. Also, if mom is having less than 30 cc's of output an hour, that is something that you should definitely document, watch closely, and notify the physician about. We need to hydrate these people to prevent renal failure if we note less than 30 cc's of urine output an hour, or 30 milliliters. And also, don't forget that a decrease in urine output is also one of those signs of hypovolemic shock. For moms that have had a C-section post-operatively, we want them to ambulate as soon as possible because we want to prevent DVTs. Nowadays, we in the hospital give Lovenox shots, we put on SCDs, we give them TED hose, depending on what your doctor's preference is. We do other interventions to prevent DVTs, but the biggest thing that we can do that mom can continue to do at home is to help her ambulate. Not only does it help C-section moms prevent DVTs, but it also helps them get rid of gas. When you open up someone's belly from a surgery, there's a lot of air that's left in there once things are closed back up. And we got to be able to get that out, or it causes a lot of pain. So if moms will get up and ambulate, it will help that gas start to dissipate. And once she starts passing gas, her pain level is going to decrease. We don't want her lying in bed and staying still, because that's going to increase her pain and increase her gas. And then turn coughing and deep breathing and incentive spirometry is important because we want to prevent pneumonia. We don't want moms to lay in bed, all those secretions to settle in her lungs, and then she ends up with an infection on top of this new surgery and now having to take care of a newborn baby. For moms who have had C-sections, we got to give them some specific discharge instructions. We want them to be aware of the signs and symptoms of infection. And really, these discharge instructions apply not just to moms who've had a C-section, but they also apply to moms who've had a vaginal delivery as well. So really, any of your patients who are postpartum, they got to know about signs and symptoms of infection. If they're a C-section patient, they have to know how to take care of their incision. If they are a vaginal delivery, they have to know how to take care of their perineum. We want them to know what normal colors of lochia and what a normal amount is. And we want to be able to explain to them that lochia is going to change. It will go from rubra to serosa and then on to alba. And we want to give them a time frame for those as well. We want mom to know that if she goes home and she saturates a pad from front to back in less than an hour, or if she starts passing clots, that's not normal and that those are signs of hemorrhage, and she needs to report that to her doctor. Also, we need to educate them about pain control and different methods to use for that. So usually what we do is have moms use Motrin. That seems to be a really good drug for women who are postpartum. Also, we want them to know what to do if they become constipated or have bladder problems. Moms who have had vaginal deliveries, especially if they have experienced an episiotomy or a laceration in the perineal area, have a real difficulty trying to pass that first bowel movement because they really feel like it's going to rip their stitches out, or it's just uncomfortable and scary. So we like for these moms to take Colace a couple of times a day to help soften their stool up so that it makes that first bowel movement not as traumatic. And then people that have had a C-section, obviously they've had they're not moving quite as much, and that puts them at risk for C-section. That puts them at risk for constipation as well. So these moms also may need to be taking Colace a couple of times a day. We also need to let them know that they need to continue to empty their bladder every couple of hours because that will help with bleeding. We don't want their bladder to become distended and not allow their uterus to contract and go back down to normal size as it should. And then with C-section patients, if the bladder gets very full, then it puts a lot of pressure on that incision site and causes them more pain than is necessary. Another big thing with discharge instructions is to make sure that patients know who their emergency contacts are. So make sure that they have their physician's office number, make sure they have the number to the labor floor where they delivered. It's important for them to have those contacts if they go home and have complications, because remember, our vaginal deliveries go home in 24 hours time and our C-sections go home in 48. Okay, so here are a few nursing diagnoses that you might want to consider for patients during labor and birth: fluid volume deficit, anxiety, knowledge deficit, risk for infection, acute pain, risk for injury, ineffective breathing pattern, powerlessness, and ready for enhanced childbearing process. You guys can read the related tos and fill in the as evidenced by at this point in your nursing career, so I'm not going to bore you with that. And obviously, the outcome that we strive for in this field is the safe delivery of the mother and the baby. We want a good outcome for both patients. But beyond that, we want moms to understand the labor process. We want her to maintain feelings of control over her labor process. We want her to stay free from infection and injury. And we want our comfort measures that we provide to her to be successful. We want her to stay hydrated, to maintain appropriate acid-base balances, and ultimately have effective bonding with her baby. Okay, so we will end Lecture 2 here and look for Lecture 3, and we will continue on talking about pain management. So this is the end of Lecture 2 for Individual Module 5.2, PowerPoint 2. Thanks for listening.